Hello, I'm Donna Mayer, the Executive Director of the Cholangiocarcinoma Foundation. We'd like to welcome you to today's webinar. We're very pleased to have Dr. Ted Hong here with us to discuss using spacers for safer delivery of high-dose radiation therapy. Dr. Hong is Director of Gastrointestinal Radiation Oncology at Massachusetts General Hospital and also Associate Professor of Radiation Oncology at Harvard Medical School. His research interests include proton therapy, targeted therapies, and biomarker development for GI cancers with a specific interest in liver tumors. He serves on the NCI Task Force for hepatobiliary cancer and colon cancer, as well as numerous other national organizations. He's the principal investigator of the NRG GI-001, the first phase 3 trial specific to intrahepatic cholangiocarcinoma performed in the United States by a cooperative group system. If you have questions today, we ask that you enter them in the box to the right of your screen, and then after Dr. Hong's presentation, I will ask those questions on your behalf. Dr. Hong will not be able to answer any personal questions during the presentation, so please be sure your questions are general in nature. Again, we're grateful that Dr. Hong has given his time and expertise, and I now turn the floor over to him.
Donna, thank you so much, and thank you for all the attendees for joining us this afternoon and spending time with us. What I'm going to be discussing today is the use of spacers for high-dose radiation therapy. And as part of a segue into that, I'll also be showing some data to try to convince you that we do think that radiation therapy does have a role in unresectable liver tumors, specifically cholangiocarcinomas. I'm aware that Dr. Crane has spoken to this group regarding some of our data with cholangiocarcinoma, and I'm just going to elaborate on that just to further clarify what the issues are and why we embarked on this program. Here are my disclosures. I do not have any relevant financial disclosures relevant to this presentation. So when one considers the use of high-dose radiation therapy for liver tumors, the primary issue is that while high-dose advanced radiation can be effective in the treatment of intrahepatic cholangiocarcinoma, our advanced radiation technologies, such as protons or IMRT, cannot solve the problem of what happens when a tumor is in direct contact with a mucosal surface. When I say mucosal surface, what I'm really talking about are organs like the stomach, the colon, the small intestine, where the doses that we deliver for radiation therapy can cause significant injury, even perforation, to those mucosal structures. So the solution that we came up with was manual displacement. Before I get into that, though, let me just explain to you why we think radiation is a modality that should be used for intrahepatic cholangiocarcinomas in the first place, because I don't think that that's really, that hasn't really been a given until we did some prospective work with MD Anderson and UPenn. So these are results that I presented at ASCO this year. What this describes is an NCI-sponsored prospective multi-institution phase 2 study where 43 patients with intrahepatic cholangiocarcinoma were enrolled into the study of high-dose proton therapy. What you can see here is that these were large tumors with a median size of 7 centimeters, all unresectable tumors. The treatment was 15 treatments given to a very high dose of 67.5 gray, unless it was more central near the porta hepatis, in which case 58 gray were given. When we evaluated our patients, we evaluated these 39 evaluable patients, and as you can see here, that this was sort of a very standard group of who has intrahepatic cholangiocarcinoma with a median age in the 60s, a fair number of the patients having childhood cirrhosis, over almost 2/3 of the patients having received prior therapy, and the majority of patients having single lesions. And what you can see here is that the tumors were generally quite large, with a median tumor size of about 6 centimeters, with elevated CA19-9s, and we were able to give a high dose of radiation therapy to these tumors. The treatments were very well tolerated, and you can see here that there's a very low risk of toxicity, and you'll notice that only one patient had a stomach ulcer, but there are no other cases of mucosal toxicity, and that'll be the bulk of what I'll be talking about in this presentation. But again, very well tolerated, and what we're able to demonstrate is that the local control was outstanding with a 1-year local control rate of 97% and a 2-year local control rate of 90%. And the overall survivals at 1 and 2 years of 69% and 44% really are quite favorable compared to what one would expect in an unresectable group who received chemotherapy alone. These results compare very favorably to the results of the ABC2 trial. And here's a graphic representation of how our patients did. And when one restricted to patients with better liver function, or Child's A, you can see the numbers are slightly better with a 1-year overall survival of 75% and 2-year overall survival of 48%. So again, a suggestion that high-dose radiation therapy can be a very effective way to treat patients with unresectable liver cancers. And this is actually what forms the foundation for the randomized trial that we're doing through the NRG GI001. But there is this problem of what happens when the tumor is in direct contact with mucosal surfaces. And what I can tell you is back in 2005, when I was initially starting our proton program for liver tumors here at the MGH, there were a number of patients that I had to turn away because their tumors were in direct contact. Now, this is with an intestine or the stomach, and this is actually an issue that's probably more relevant to cholangiocarcinoma compared to hepatocellular carcinoma or liver metastases, and that the majority of cholangiocarcinomas tend to be central tumors, which are very close to these mucosal surfaces. And we were turning patients away at that time because we did not feel that it was safe to deliver these high doses, aggressive doses of radiation therapy without a substantial risk of damaging the intestines. So what we did is we came up with a solution of putting in these biological mesh spacers to separate the tumor from, or the liver surface from the mucosal surface. And we published these results in Practical Radiation Oncology in 2014. The first author was my colleague, Dr. Sam Yoon, who's a surgeon that I collaborate with. Now, like many things that we do, we did this in collaboration with MD Anderson, and we did this in 14 patients. This was a retrospective review. Since this time, we've done it in many more patients. But this initial publication was in 14 patients, and patients were selected if the tumor was in contact or within 1 centimeter of a mucosal surface. The biological spacer that we use is a product called Alloderm, which is made by LifeCell. What Alloderm is cadaveric human skin that's chemically processed to preserve the structural and biologically active dermal matrix. Because the chemical processing takes out any live cells, essentially you're left with a hypoallergenic biologic material that can then be sort of folded and manipulated in many different ways. Now, because these patients were being taken for high-dose radiation, and what we didn't want to do is a big operative procedure that we wouldn't be able to proceed with radiation planning for several weeks after the procedure, a real effort was made to develop this technique to be done laparoscopically as a same-day procedure. So at the time of the placement, the surgeon would place a 12-millimeter Hansen port at the periumbilical region, and then additional 2 5-millimeter ports and 1 12-millimeter port as well. Lysis of adhesives was performed if necessary, and then sheets of this Alloderm of 8 by 16 centimeters were folded into a 3-layer sandwich and sewn at the 4 corners. And this is what the spacer looks like. So in panel A, you can see what the folded spacer looks like in the so-called sandwich. You can see that it's like a white pad now once it's folded over. And then what you can see is on panel B is this laparoscopic, this Alloderm sandwich being sort of stuffed through the laparoscopic port in panel B. So that's the skin of the patient that you're seeing, and the port is being stuffed through the hole. And then C is the intracavitary view, so what you're seeing through the laparoscope. And in the upper left, you can see the liver surface there, and you can see this white sheet being laid between the liver surface, which is in the top left, and the intestines, which you can see as sort of bubbling up underneath this surface here, here in the bottom right. So when we looked at the patients that we took care of, you can see, as I had mentioned before, the group that's most represented were actually, again, cholangiocarcinoma because of the location that these tumors tend to be in. So 6 of the 14 patients had cholangiocarcinoma, 3 of the patients had HCC, and then 5 of the patients had various kinds of metastatic disease. And what you can see is that the organs that were displaced varied. It was sometimes the stomach, sometimes it was the duodenum, sometimes it was the small bowel, and sometimes it's the colon. But if you look at the mean distance between the tumor and these organs before the placement, you can see that generally in millimeters, it was between 6 to 10 millimeters. After placement of the spacer, you can see that the distance between the tumor and the mucosal surface was very forgiving. It was on the order of 3 centimeters, with a net change of approximately 2 centimeters for all of these mucosal structures, validating that this is a highly effective way to move these organs out of the way. Because of this, this allowed us, as you can see here, the increased space allowed us to give very aggressive doses of radiation. So you can see in the far 2 right columns, you can see that we were giving high dose per fraction to very high doses, and this was only made possible by the increased distance that the spacers permitted from the tumor to the mucosal surface. The other important thing as well, clinically, did this actually lead then to protection of the GI organs? And what you can see here is that if one looks at any gastrointestinal ulcer or bleeding of any grade, in these patients there were none, which is really pretty impressive given that before we started doing this procedure, I just would not have treated these patients for concern of causing gastrointestinal ulcer or bleeding. This is an example of a alloderm being placed on a tumor. This is a patient of mine with cholangiocarcinoma. And what you can see here is the gallbladder and the tumor. Here, there's some omental fat here. The tumor is up here. And the alloderm is being draped around this area of the tumor here. And you can see here how the alloderm is really sort of being draped all along this liver edge here. And here it's being sewn, so now you can't see the liver. The liver is completely hidden by the alloderm. And you can see the small bowel and duodenum, and all it's in contact with is the alloderm as opposed to the liver and tumor itself. This is the same patient. What you can see is before we put the alloderm in, the bowel was directly overlaying the tumor here. And then you can see the alloderm here dotted out in red, and you can see, look how far away now the bowel is from the area of the tumor. This allowed me to give a high-dose proton plan safely to the area of this tumor, with the intestine represented over here in yellow, and plenty of separation now for me to give this very high dose of radiation. This patient received 10 gray per fraction to a total dose of 50 gray. This is another patient of mine with a very large cholangiocarcinoma. You can see this very large tumor here, outlined here. You can also see this, the high dose radiation, and again, dotted in red, you can see the alloderm spacer, and you can imagine that if the stomach was here, it would actually be receiving full dose. But with this Alloderm spacer in place, I was able to treat the patient and avoid the stomach. And you can see again, in follow-up, you can see the post-treatment changes. You can see the decrease in size of the tumor, the liquefaction of the tumor. You can see the Alloderm spacer is still in place and the stomach has been well protected here. So in conclusion, high-dose radiation is an effective treatment for intrahepatic cholangiocarcinoma, and these biologic mesh spacers can allow patients to receive these treatments that would otherwise not be able to receive this therapy, and that these spacers are associated with safe radiation treatments, even very aggressive radiation treatments. I'd like to thank the colleagues that I work with that put these in surgically, Dr. Yoon, Dr. Muller, and Dr. Haynes, who used to be at MD Anderson and has since actually come to the MGH. Chris Crane from Radiation Oncology at MD Anderson, and Jennifer Wu, my colleague in Radiation Oncology here at MGH. I know this is a relatively brief presentation, but this is all the clinical experience that has been reported to date. We are now routinely using Alloderm in patients whose tumors are in contact with the mucosal surface. And again, it has eliminated that barrier in delivering what I think is a very effective treatment for intrahepatic cholangiocarcinoma. At this time, I'll pause and be happy to take any questions.
Thank you, Dr. Hung. We do have a few questions, and as I'm asking them, if you think of other questions, the listening audience, please feel free to submit them in the question screen. One of the questions is, does the Alloderm graft get removed at any point in time?
No, the Alloderm graft is left in there permanently.
Okay, and why is it only intrahepatic patients, cholangiocarcinoma patients, are being looked at as, is this possible for other patients with cholangiocarcinoma to participate in this?
I think that I certainly think it could be. I think that the issue right now is there's some ambiguity about what is a safe amount of radiation to give to an extrahepatic cholangiocarcinoma. I'm recognizing that the dose limiting, there's some concern about how much radiation can we safely give to the bile duct without causing a stricture. Having said that, you know, we at Mass General have been interested in considering dose escalation in those patients. And in fact, our current we have recently, following Mayo Clinic's lead, have opened a hepatic transplant, liver transplant protocol for extrahepatic cholangiocarcinoma that is very similar to Mayo Clinic's, except instead of mandating internal radiation as a boost, we're actually allowing for either protons or SBRT as a method for boost. And in that situation, I can see us potentially needing to use Alloderm in those patients.
Okay, thank you. And one other question. If someone has multiple tumors, are they precluded from having an Alloderm graft?
Multiple tumors is not the issue. It's more a feasibility of can we do it with radiation. I've treated up to patients with up to 4 metastases or cholangiocarcinoma lesions in, with radiation. So for that case, I would say that certainly Alloderm could be considered if needed. So it's not a number of, the Alloderm and number of lesions is not the issue. The number of lesions is really more, is it safe to give high dose of radiation when people have many tumors?
Okay, thank you. Well, there doesn't appear to be any more questions at this time. So on behalf of the Cholangiocarcinoma Foundation, I'd like to thank you again. We truly appreciate the presentation that you shared today. And for those who are participating in the webinar today, I want to let you know that we will be posting the recorded webinar and the PowerPoint slides on the Cholangiocarcinoma Foundation website. If you have any additional questions, please post them on our discussion board and we will make sure that you receive a response. So thank you to all who participated. The webinar will end now.